Hi everybody, I'm Dr. Roth. Welcome to week 1 of SLP 570. So just as a reminder, I like to do these little mini lectures. They do not replace the need to read your textbooks, your articles, or do the assignments, but I do like to offer this as just like a little bit of fortification of your learning and just to kind of hear some of the content presented orally and to think through some things. And I do not include slides for these. Just because, first of all, it's just a little mini lecture, but second of all, I really want you guys to take notes. When we take notes, we internalize what we're hearing, we synthesize, we write it out. It actually stores in a different area of our brain. So we're just gonna take notes, write down what stands out to you, write down anything that may seem relevant for your assignments, and just generally take in what we discuss. Okay, so let's go, week 1. Okay, so for chapter 1, we discuss the core features of developmental language disorders. It's also just an introduction to language development and theories. But for developmental language disorders, we discuss, what that refers to is persistent difficulties acquiring and using language without an obvious cause. So for example, no hearing loss, it's not caused by autism or neurological damage, because that would be like a TBI, for example. So characteristics you're going to look out for are delayed vocabulary and grammar development, overly simplistic sentences for the age, difficulty understanding language, so impacts in like listening and receptive language, and problems with discourse and social language. So use of pragmatics. And that's really good to be aware of because pragmatic difficulties could be due to like an autism, or it could be just a more general language disorder. And it occurs across all modalities. So the language disorder should be present in spoken, written, sign language, and even in other languages if they're bilingual. It should be in language 1 and language 2 or 3 or 4. Okay, so as things important to know, this actually used to have another term. It used to be called specific language impairment, or more generally, language delay. But there was a lot of confusion among professionals about the significance of these different names, and are they the same thing, are they different? So we've actually updated the term to DLD, and it is the name for a developmental language delay disorder. It's even in the DSM-5, so it's actually a disorder, not just a general description. And this change helps to recognize heterogeneity across professions, and that can include other professions, such as maybe some other professionals you may be working with in like the school-based setting or medical settings. And a new change for this, DLD criteria, is we're also moving away from the normal IQ requirement as a strict cutoff. So instead of saying, oh, well, they have to have a normal IQ to have DLD, that is not the case anymore. It is more of a functional diagnosis. So we look at aspects and modalities of communication when examining for DLD or treating for DLD. And we might look at form, content, and use. So those are the main categories of language. So form includes phonology, morphology, and syntax. Content is semantics or meaning. And use is pragmatic, so that social communication piece. And again, we will look at all modalities such as spoken, written, signed, AAC, and bilingual language expression. Okay, and next we are going to look at some diagnostic issues to consider. So historically, we used a discrepancy model, and what that means is the language ability had to be less than the nonverbal IQ. So for example, now today, that's kind of how we look for learning disorders, like the learning, that category, whether it be reading or math, needs to be not as high as we would expect for their IQ. So we used to expect that for language as well. With DLD, that is not the requirement anymore. Nonverbal IQ is not required to be normal for DLD diagnosis. There should maybe still be that discrepancy, but it doesn't need to be normal. And we're going to focus on functional language impairment. So is their communication impaired? Is it impaired across content form and use? Is it impaired in both languages at home and at school? Like, that's more what we're looking for. Challenges. So when diagnosing, it can overlap with other conditions like autism, ADHD, learning disabilities. And then, of course, we have to always consider those cultural and linguistic biases and assessment, and always be very wary of that and make sure we're not accidentally diagnosing somebody with DLD when really we're assessing them in English, when they're bilingual, or even maybe just partially exposed to another language at home and it's impacting their scores. Okay, so a biological base of DLD. So researchers use some different categories to examine DLD. They look at genetic studies, such as family twin studies, bloodline, that kind of thing, family presentation. Neuroimaging, so brain structure and functional differences, and electrophysiology, like the EEGs. So findings suggest that DLD has biological and genetic influences. It is a difference related to a language-related brain network issue. So it's a brain-based disorder. And so, for example, we would normally consider Broca's area or Wernicke's area when thinking about speech and language. We will consider these areas. That's, for example, a brain-based language disorder. And there's a couple of models that look at, where is this occurring in the brain? So there's a few different perspectives. There is the linguistic deficits model, such as being influenced by grammar-specific impairments. There is processing limitations, which might consider issues such as reduced working memory or slower processing speed. There's also domain general models, which means just broader cognitive weakness. And that's kind of why I mentioned the Broca and Wernicke's areas before. So those are kind of classic kind of language-based brain areas. But this domain general model just kind of talks about, there just might be like general cognitive impairment. So clinical implications. So knowing all this helps us to design therapy. So we might, for interventions in therapy, we might target language structure and processing skills, a little bit of both, because there can be that processing speed. Like, for example, in therapy, we always want to give them a good 2, 3, 4, 5 seconds to respond. Find out how long it takes them to do that processing. But we also want to fill in the gaps of their language structure. Like, are they struggling with certain areas of grammar? Do we need to hit certain areas more than others? And therapy should be extensive. Give them as much as they need. Give them a lot. Explicit, very clear, target each individual thing very clearly, focused practice, and functional. We always want to be treating speech and language skills, whether it's speech or language or swallowing or voice, with a functional purpose. Doesn't help to teach a child, the list of all of the US presidents if they can't ask for a cup of water. Okay, so nature versus nurture. This is when we start getting into the theories. Okay, so nature, that kind of perspective argues that there's a genetic predisposition to language. And so there's maybe as it responds to DLD, that might be a genetic predisposition to DLD. Nurture, it could be environmental, such as language exposure or interaction quality. And that's another perspective that's kind of like maybe more of the behaviorist perspective. But the current view is, and kind of the favored view, is the interactionist model, which means both matter, nature and nurture matter. But the clinical takeaway is, we never want to blame the parents. So a child likely would have had DLD one way or the other. Language-rich environments, nurture, language-rich environments might help support DLD, but an environment doesn't cause DLD. It's a brain structure disorder. And so we want to work on the brain targets as well as the nurture or environmental targets. Okay, so we're going to look at factors influencing communication development. So factors influencing communication development. How does language form in a child? So we want to consider things like biological aspects such as hearing, cognition, neurological status. Like all of this is going to impact the ability to acquire language. And like hearing, for example, I know they're trying to give cochlear implants, earlier, so that even if they can't hear things clearly, they're kind of getting that language exposure. And actually they're finding that that's helping with reading acquisition, because they're getting to pair a little bit of the sound with reading. So you can obviously learn language with hearing. We know ASL, but it's just a consideration, could delay things, especially if it's unidentified. Environmental. So that's caregiver interaction, language exposure, socioeconomic contexts, how, the quality of, how often the caregiver can speak to them, what level of language they're exposing them to. Do they value speaking to a child, or is that not a part of their cultural or socioeconomic culture? So these are all things to consider. Social aspects, we're going to look at joint attention and responsiveness. So if they're struggling to have joint attention, like shared interest on an object with the caregiver, they're going to have a lot harder time developing, for example, vocabulary and naming items. Responsiveness, if they're struggling with social and they don't really understand, they don't like innately understand that kind of back and forth communication, they're not going to get maybe requesting as easily, or communication skills as easily, or shared experience as easily. And what we know from autism, even though this is not autism, this is DLD, what we know from autism is it's no one's fault. But when that child doesn't give that back and forth, the caregivers just unconsciously might not initiate or respond as frequently, because they also don't have a communication partner. So that's how social can affect language development. And then cognitive. So there's memory, attention, processing speed. And processing speed is a big one. And we as SLPs like to talk a lot, as you can see. And we like to talk fast. And we like to help out. And we like to give them the word that they're looking for. But we actually need to identify their processing speed, and we need to give them time to think, because they need to practice responding. So if you have a book and you're working on colors and you're saying, what color is his shirt? Red. Yes, red. Did you feel how long that felt? That was 3 to 4 seconds. So a lot of times they'll surprise you. If you wait, they might have it. And we want them to produce the language, because then they're more likely to use it, practice, and it will get faster. But we have to work with them and meet them where their processing speed is. Okay, applications for us as SLPs. All right, so actually I skipped one. Language acquisition theories. So the book, and actually one of your articles, talks about the nativist, behaviorist, and social interactionist theories. So Chomsky argues that, the nativist is nature. It is like an innate language box in one's brain, and every language, it's innate, in all children, even if they speak different languages. The behaviorist is Skinner. He's our behavior guy. He is also famous for applied behavior analysis. But he's going to argue that it's actually a nurture thing, and that it's learning via reinforcement. So we learn language because we are reinforced as babies when we make a sound. We learn language because we are reinforced as a 1-year-old when we accidentally say a word. So as you can see, you can probably guess, there are good elements to both the nativist and behaviorist theories, but they leave a little room for, the need for more explanation. So then there's a third theory called the social interactionist perspective. And this argues that language develops through interaction. And that might be more of like a Vygotsky or Piaget model. And that actually aligns, like here we're calling it the social interactionist model. Earlier we said nurture versus nature. We're like, yes, nurture versus nature, but better yet, interactionist, because you're going to take both elements into consideration. Like you're using the child's innate ability to learn language and grammar, but you're also building on it. You're modeling. You're getting excited when they say mama, 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 or baba. You're saying, yes, baba, here's your milk, here's your reinforcement. But it's all that interplay. So the interactionist model kind of takes all perspectives together. And it is, I think, at this day and age, probably the favored perspective. Although let's not throw out nativists and behaviorists because they also have crucial and important characteristics. So applications to use as an SLP, ideas for therapy. So we obviously want to use modeling and reinforcement. So that's a little bit of a mix between the interactionist and behaviorist. We're going to model what we want them to say. We're going to let them try. When they try, we're going to reinforce them. If they're incorrect, we might say, nice trying, and stay engaged with them. But if they're correct, we're going to say, that's correct. You said shirt is red. The shirt is red. Good job. And build that language structure. You might recognize innate language constraints. This kind of like maybe leans more to the nativist theory or the nature theory. So for this, we're going to possibly consider categorical milestones. For example, we might think of our general SLP rules like 2 words by 2, 2 by 2, 2 word combinations by 2 years old, 1 word by 1, 2 words by 2. So that's kind of like that development. We would expect to see this across the board. If we're not seeing that, then we're going to maybe work on those delays. Bottom line for us as SLPs, the takeaway. So DLD, as a review, it is common, heterogeneous, and biologically influenced. It is a brain-based disorder. It is a formal term for a developmental language disorder. It should be used across the board. We are not saying language delays or SLI anymore. The vagueness kind of got us into trouble with like IEPs and working with other professionals. We're not doing that. DLD, developmental language disorder. Diagnosis is moved towards functional impact, not strict IQ discrepancies. So we probably are going to consider if there's a discrepancy. Is their nonverbal language higher than their language presentation? But it's not as black and white as it used to be. But I mean, at the same time, if we do see a big discrepancy, that is a red flag for us. But we're just not held to that requirement. Language equals form, content, and use. So that's all of our language areas like pragmatics, syntax, semantics, all that kind of good stuff. And we're going to look across multiple modalities. We need to double check ourselves. Is it in writing? Is it reading, spoken, listening, bilingual? We don't want to jump the gun and maybe it's only a writing thing. Or maybe it's only a language 1 and language 2 thing. And then there's effective intervention integration. So when we're designing, therapy, we want to just kind of create like a comprehensive plan. So we want to consider cognitive processing and linguistic structure and social interaction. And then lastly, we want to make sure that development is shaped by both biology and environment. And I'm realizing I just skipped a really fun one. So I was giving you examples for, modeling reinforcement, which is maybe a little bit of that behaviorist, instructional, maybe a little bit interactionist. There's recognition of innate language constraints, nativist, 2 words by 2. But when we're doing the interactionist method, we're going to focus on meaningful communication. And how we're going to do this, this is my favorite, especially for the little ones. We're going to do like play-based therapy. We're going to do following the child's lead, expanding on what they're saying. Maybe if they said it wrong, say, oh, you told me, they say, that girl shirt red. Yes, that girl's shirt is red. You're right. It is red. And we're going to kind of like highlight those areas while still engaging and playing. We might create communication opportunities and temptations to give them that opportunity to practice. So a famous one, and you'll hear me say this probably every time you have me because it's one of my favorite techniques. But like, for example, if you have a little kid with autism or a language delay or any sort of expressive, you're going to make them, put them in situations where they have to use language. So for example, if they love playing in the water, you're going to walk up to the sink. It's going to be a sink that's too high for them to reach, or the faucet's too high for them to reach. And you're just going to wait. And they go, what? What do you want? And depending on their developmental ability, you might wait for them to say, want, or water, or want water, depending on where they are. And they go, oh, you want water? Okay, climb on the stool. Let's play in the water. So that's creating a communication opportunity or temptation. And then we want to do rich language exposure. And that's something you can coach the parents on at home. But we know that like radio and TV does not take the place of spoken language from like an adult or sibling or caregiver. It's not that it doesn't do anything. It just by far does not replace spoken language to the child. So we want to coach them on speaking to them, reading to them. Maybe we can even provide them books, like really expose them every single day to more language. We're going to work on language exposure during play. We might even work on categorical language exposure. Maybe we work on, doll houses for a few weeks and build that kind of the pretend play vocabulary, but then maybe working on food for a few weeks, and we're really building that back and play of language for food, requesting, naming, labeling, favorites. Can the child request for their favorite language or favorite food, favorite drink, favorite snack? And that's it. So a lot of information, but a really good overview. Again, if you didn't take notes, maybe go back and take notes. This does not replace your need to read. This does not replace your need to, read your research articles. Don't just skim. Don't just, let AI do the mental work for you. You will not learn this content. It's dense, and so is all the other content in our program. So you're going to use this as a supplement. You're going to use your book as a supplement, as a required reading supplement. Your assignments, maybe you're supporting your writing with a little bit of outline draft help from AI, but then you're finding research articles and you're reading them. Another great learning thing we want you guys to do is to be using explicit examples. Stay away from the general, you're going to lose points. We want explicit examples because we want to know that when you go into that therapy room, you know exactly what you're going to do. So you're not going to say, I'm going to do social reciprocal communication with a 2-year-old. That's not enough. What does that mean? Are you going to, when you walk in a therapy room, are you going to do social explicit communication with a 2-year-old? No, what you're going to do, yes, but you're going to do, I'm going to crawl on my hands and knees. I'm going to roll the car in front of them. I'm going to do child-led play and watch them follow the car, and I'm going to comment when they're doing that, and they're going to look at me and we're going to smile and we're going to have a silly interaction, and he's going to enjoy sharing language with me. That's an example. All right, so you guys got this. Week 1, we have a fun semester ahead of us, and I wish you guys good luck. Bye. Oh, and you got this.